Welcome to Physician Focus. I'm Dr. Linda Young. Crohn's disease and ulcerative colitis are two forms of inflammatory bowel disease, a general term that describes a chronic inflammation of the gastrointestinal tract, part of the body's digestive system. Crohn's and colitis each strike as many as 700,000 Americans, with both men and women equally affected. Though their origins and symptoms are similar, the two conditions have distinct differences and affect different areas of the digestive system. This edition of Physician Focus will provide an introduction to Crohn's and colitis. We'll look at their causes and symptoms, the consequences they can have on a person's health and quality of life, and the treatments available for them. Our guest for this program is Dr. Andrew Warner. Board certified in internal medicine with a subspecialty in gastroenterology, Dr. Warner is chairman of the Department of Gastroenterology at Lahey Health in Burlington, Massachusetts. He is an associate clinical professor of medicine at Tufts University School of Medicine and a clinical instructor in medicine at Harvard Medical School. He is also the co-author of 100 Questions and Answers about Crohn's disease and ulcerative colitis, and the editor of 100 Questions and Answers about Your Digestive Health. Welcome, Dr. Warner.
Evening, Linda.
So this is a very interesting topic, and I think it's very confusing. So there's colitis and there's Crohn's, and I think it's very confusing to sometimes healthcare providers and also to the patients that have been diagnosed with this. Can you kind of go into a little explanation about the nature of these two entities?
Sure. Crohn's disease and ulcerative colitis are both chronic inflammations of the intestinal tract. This is a picture of the intestinal tract, just to go over it. And this is our body's digestive system. When we eat food, the first thing that happens is we chew the food, and that is the first thing that happens to allow food to break down. It goes down the esophagus into the stomach. The stomach is also where food is broken down to much smaller particles. After leaving the stomach, it goes into our small intestine. The first part of the small intestine is called the duodenum. That's where we get duodenal ulcers. Second part is the jejunum. And the last part down here is the ileum. Small intestine is very important. That's where food is digested and where nutrition really occurs. Once the food gets through the small intestine, it's all liquid, and the liquid goes down to the colon, also called the large intestine. The purpose of the colon, or the large intestine, is to absorb all the excess fluid, and as it goes through the colon, it becomes more solid and then goes out through our rectum. With ulcerative colitis, it's a disease that's really just to the colon. It starts in the rectum and goes throughout the colon, and it never enters the small bowel. That's why it's called colitis.
Colitis. So just a question, a lot of people think that the large intestine is the biggest part, but in fact, the small intestine is bigger.
That's correct. The large intestine has a bigger diameter. The small intestine has a smaller diameter, and that's where they get their names. But the small intestine is actually about 17 feet in length.
Yeah, it's a lot
much larger.
Inside.
A lot of stuff inside. Whereas the colon, the large intestine, is only about 3 or 4 feet in length.
Okay, so it's interesting because I know a lot of people think, oh, well, they don't realize how many feet of intestines are actually inside them.
All total, we have about 23 to 25 feet of intestines, all scrunched right inside of there.
So we have colitis, and then so what would Crohn's disease be?
Well, colitis, again, is inflammation of the colon. Now, a lot of different things can actually cause colitis, but the one we're talking about tonight is ulcerative colitis. Now, Crohn's disease, unlike ulcerative colitis, can affect any part of the GI tract. So whereas ulcerative colitis is only in the rectum and colon, Crohn's disease can be in the stomach, the esophagus, the small bowel, or the colon. Now, for most patients, about 70%, they will have involvement of the small bowel, and that's one of the ways we differentiate between the two. About 20% of patients will actually have involvement just to the colon, and sometimes that can be a little confusing because we call it Crohn's colitis, which is really Crohn's disease of the colon. We like to be confusing sometimes.
All right.
Now, the two diseases present differently. With ulcerative colitis, it presents as rectal bleeding or bloody diarrhea. Crohn's disease usually presents with non-bloody diarrhea and abdominal pain. And since Crohn's disease involves the small bowel, which is where nutrition occurs, patients with Crohn's disease often end up losing weight as well because they're not being nourished.
I think one of the important things, I'm a pediatrician, and I know in Crohn's disease in children, often the first thing that happens is they don't grow very well before they even have any symptoms whatsoever because of the nutritional component there.
That's absolutely true. Every parent knows that the first thing that happens when you bring your child to the doctor, to the pediatrician, is that they weigh the child, check their height, and see where they are on the growth chart. Now, most people think it's because we want to know how tall the children are. Really, that's not what we're interested in. What we want to make sure is the children are healthy. And if the child is healthy, they're growing at a stable rate. When all of a sudden someone stops growing at that rate, or what we call falling off the growth curve, it means there's probably some disease. And in the case of Crohn's disease or even ulcerative colitis, the first thing we see long before there are symptoms of Crohn's and ulcerative colitis is a child stops growing.
Mm-hmm. How about, are there any risk factors at all, or just in general, is there a population that may be more prone to this? Is there some kind of gene marker or hereditary component to any of this?
Well, the truth is we really don't know what causes Crohn's disease and ulcerative colitis. We know it tends to be familial. Not familial in the sense that if a parent has, their child's definitely going to have it. But if a child has Crohn's disease or ulcerative colitis, or if anyone has it, there's a likelihood that there's someone in the distant family that has it. Maybe an uncle, maybe an aunt, maybe a cousin. Mm-hmm. So it does tend to run in families. There is a genetic basis for Crohn's disease and ulcerative colitis, and we're learning more about that every day. But there's no specific risk factor. In fact, one thing we often try to tell patients is that there's nothing they've done to bring this on, and there's actually nothing they could have done to prevent this. A lot of their friends will say it's because you work too hard, you're under stress, you eat the wrong things, you exercise too much or not enough. In fact, we don't know what causes it, and there's nothing someone did to bring it on, and really nothing they could have done to prevent it. Unfortunately, it's something that just happens.
I think there's and it might be a misconception that once you're diagnosed with it, that stress can actually have a lot to do with making it worse. Is that true?
Well, certainly stress does not cause Crohn's disease or ulcerative colitis, but anyone with any type of ailment who's under stress will probably feel worse. Mm-hmm. It's not actually making the Crohn's or ulcerative colitis worse. It's just making the person with Crohn's or ulcerative colitis feel worse.
Ah, okay. How about just in general, is there any ethnic group that tends to be more prone to it?
We used to think it was more common in Jews, and particularly Ashkenazi Jews, and that's still true. But we're seeing Crohn's disease and ulcerative colitis all throughout the world in all different ethnicities. So it's growing in incidence. There's more people with Crohn's now than there were many years ago, and we're seeing in all different populations.
How about, I had mentioned in the introduction that in America, about 700,000 people are diagnosed with it. Does it tend to be diagnosed early, or can it occur from age whatever to whatever in the spectrum?
Well, Crohn's disease and ulcerative colitis tend to start in the late teenage years and go through the early 30s. But we can diagnose patients with Crohn's disease or ulcerative colitis as young as 5 or as old as 85. Mm-hmm. So where the predominance is in the teenage to early 30s, you can really get it any time in your life.
You mentioned about the symptoms. In other words, how does somebody feel when this first comes on? So can you go a little bit more into, I'll say, let's do colitis. You had mentioned bloody diarrhea. So when would somebody actually, if that should happen to them, when should they seek medical attention?
Well, anyone who has any type of bleeding, rectal bleeding or otherwise, should call their doctor right away. So if you're having rectal bleeding or bloody diarrhea, really the next thing you should do is call your doctor, because that's something that really isn't normal.
Yes.
If it's non-bloody diarrhea and this lasts for a day or two, that's probably not necessary. That could just be something you ate or because you're under stress. But anytime you have rectal bleeding, I'd really encourage you to let your doctor know.
Absolutely. I think that is something, instead of saying, oh, it'll go away or it'll be better, I'm not sick, I don't have any fever, it'll get better. And does it sometimes do that? You can have it, maybe you have bloody diarrhea once or twice, and then it does go away for a little time and then come back?
Absolutely. In fact, very typically, when we diagnose someone with ulcerative colitis, they'll tell us that for 2-3 years, they've been having on and off rectal bleeding. They thought it was just hemorrhoids, maybe something they ate, and it went away. So ulcerative colitis often does have this wax and wane pattern.
How about, does Crohn's disease have that too?
Yes, and most patients with Crohn's disease are diagnosed years after they start having symptoms because they're very nonspecific. Abdominal cramps after you eat, maybe some bloating, maybe you don't feel you're digesting your food properly. So usually both these diseases, we diagnose it months to years after the patient first presents with symptoms.
I know even in kids, in children, looking back in my practice, I had children that were diagnosed with this, and it was really not often chronic abdominal pain, but other things. They had joint pain, which was a big presenting thing, and unfortunately it kind of got us to go down the joint pain road, and then maybe months later they started to have some abdominal pain, and then the diagnosis was made. So it isn't that easy of a diagnosis, I would imagine.
That's absolutely correct. Earlier on I said Crohn's disease and ulcerative colitis were diseases of the digestive system. That wasn't entirely true. It's predominantly in the digestive system, but they're really what we call systemic diseases. They can affect the entire body. We commonly see, as you mentioned, joint aches and pains, and sometimes true arthritis. It can affect the skin, the eyes, the liver, the mouth. So Crohn's disease and ulcerative colitis can present with what we call the extra-intestinal manifestations, or the joint, skin, and eye symptoms, and that can come first.
So you mentioned that we don't know what causes it. There must be some kind of theories out there as to what, since it affects so many parts of you, not just the GI tract. What are some of the theories, or actually maybe some of the things that have proven that may have been a cause?
Well, right now nothing's been proven as a cause, but the biggest theory is what we call the hygiene hypothesis. As many people know, we're seeing increased incidence of all types of autoimmune diseases. Childhood allergies, food allergies, peanut and nut allergies are on the rise, childhood asthma, childhood diabetes, childhood arthritis. And we think that's because we're living in a very hygienic or extraordinarily clean environment in which for thousands of millions of years humans have grown up in the dirt, eating bacteria, eating parasites, and that was a normal part of our gastrointestinal tract. And these parasites would stimulate the gastrointestinal tract. Now without these parasites, because we're so clean, that stimulation isn't there, and our bodies aren't developing the antibodies necessary to fight different things. And so Crohn's and ulcerative colitis, like many other things we're seeing in children, we think it's because it's such a hygienic environment we're living in.
That's interesting. I just remember my grandfather used to tell us that kids needed a good layer of dirt on them to be healthy. And see, he was right.
Grandpa was right.
There you go. There you go. So I have seen firsthand the effect that this has on children, and you certainly have seen it on both children and adults. Can you tell us a little bit about what sort of a life do they have? What is the implications of the diagnosis, and how does it affect their daily living?
Well, first off, most patients with Crohn's disease and ulcerative colitis have a perfectly normal life. Just like someone who has arthritis or someone who has asthma, you learn about the things that precipitate it that make it a little worse. You know what to avoid, how to treat it, and most patients with Crohn's disease and ulcerative colitis, as long as they're under the care of a physician, can live a normal, healthy life. The best example I know of is that of President Eisenhower, who first got symptoms of Crohn's disease back when he was in his 20s, and led a very successful military career, Supreme Commander of Allied Armed Forces in Europe. And it wasn't until he was actually running for presidency the second time that he was even diagnosed.
Wow.
So people with Crohn's and ulcerative colitis can live very normal lives, again, as long as they are under the care of a physician, know what to look for, know what to watch out for, and know how to treat it.
So how about, I'm thinking of the teenagers in my practice that had been diagnosed, and I think a lot of it would be just their general lifestyle when they started to have diarrhea, when they started to have the abdominal pain. It really had quite an impact on them. It was difficult for them to play sports. It was difficult for them to be far from a bathroom, truthfully. And I think that one of the things that we had to do was to encourage them to be as normal as possible. I would imagine that would be one of the more successful things that you could tell a patient.
Yes, when we try to figure out the impact of Crohn's and ulcerative colitis on a child or adult's life, the questions you're typically asked is how many times do you go to the bathroom, how much abdominal pain do you have, how much weight have you lost? But there are really more important questions, such as if you're a child, do you ever miss school? Are you afraid to go out on dates or out with your friends? If you're in business, do you know where every bathroom is? Are you afraid to go to boardrooms? That's what we really need to ask, and that's what tells us more than anything else the impact. Unfortunately, there are a lot of adolescents who are not able to engage in after-school sports, not able to go to dances, not able to go on dates. And when that happens, that tells us we really have to up the treatment and give treatment that's going to be more efficacious.
So let's get into treatment. What is we can start at the very beginning. What's the first thing you would do?
Well, the first thing we really do is dietary treatment. If someone has a diarrheal illness, the last thing you want to do is give them foods that cause diarrhea. So very commonly, everyone wants to have a healthy diet of lots of fruits and vegetables. But for someone who has diarrhea, fruits and vegetables may not be the best thing.
Can I ask, actually backing up a little bit, how do you diagnose it? Is there a blood test? Is there an x-ray? Is there something that says, yes, you have it?
Well, Crohn's disease and ulcerative colitis are diagnosed by a number of modalities. First is someone's symptoms. Someone is having rectal bleeding or bloody diarrhea, someone's having abdominal pain after they eat, or they're losing weight, or all of them. So with a combination of different symptoms, we're often able to initially have an idea of what's going on. Then the major ways we diagnose it definitively are with x-rays or with endoscopy. The two x-ray.
What's endoscopy?
Endoscopy is when we sedate a patient and then we take a very thin, flexible tube with a camera at the end, much like a garden hose, but much thinner. And
That's good to know.
It is. And there's a camera at the end. It allows us to visualize the inside of the intestinal tract. And we can actually see the Crohn's disease and ulcerative colitis. The x-rays that we use most commonly is a CT scan or CAT scan of the abdomen, which can look at all the structures in the abdomen and see if any of them are inflamed. And we can also do what's called an upper GI small bowel series, or an old-fashioned barium swallow, where someone drinks this thick, chalky white stuff, and we take x-rays as it goes down the digestive system and see if there are any signs of Crohn's disease.
So the difference would be the x-ray you would need to have, you need to drink something. You can't just stand before the x-ray.
That's correct.
The CAT scan, that's the one where you go in that tube and they can see, what do they see on CAT scan with ulcerative colitis or Crohn's?
Well, you can see bowel inflammation.
Aha, okay. And that is that all that you need to see to make the diagnosis?
Well, if you see bowel inflammation along with the right story, that's often all you really need to know.
Is there a blood test for it?
There really isn't. In blood tests, we can tell if someone has complications from the Crohn's disease or ulcerative colitis, such as they're becoming anemic or becoming malnourished, but there's really no blood test to diagnose this.
I think with anemic, it's because they're losing blood when they have bowel movements. So their blood level or their iron level goes down, and that you can see in a blood test, but that's very generic look. But it would tell you how severe, perhaps, the disease may be?
That's correct. And with Crohn's disease, it's really microscopic blood loss. You may be losing blood microscopically without even knowing it.
So you don't even see it?
You don't even see it.
Is there a test for that?
There is a test to see if there's blood in the stool, but most commonly we just really look at the blood count and see if there are signs of anemia.
Okay. How about, so now we can kind of fast forward a little bit to the treatment again. So what would be, I'll let you decide which one you want to talk about first. Are they the same treatment?
For the most part, treating ulcerative colitis and Crohn's disease are very, very similar. There are a number of different classes of medications that we use. One of the most common ones are steroids, commonly such as prednisone. These are drugs that are used for any type of inflammatory problem, whether it's asthma or poison ivy. And steroids are very good to cutting down inflammation rapidly. They're good drugs for short-term use. They're nothing we really want to use long-term. But for someone who is acutely ill, really having a lot of symptoms, losing weight, can't get out of the bathroom, are anemic, we may want to start off with that just to get things under control.
Obviously, steroids have a bad connotation. We're talking about different things between enhanced steroids, such as you read about in the sports world, and prednisone, which is such a wonderful medication to help everybody with a variety of problems. So that's your first line. That's what would happen.
For someone who's very ill, that would be my first line, because that works very quickly. But very often, someone has much more mild symptoms, and that may not be my first line. Very often, we use a class of drugs called aminosalicylates. These are anti-inflammatory drugs that are marked that work on the colon and the small intestine. They're not anti-inflammatory drugs like ibuprofen or naproxen, which work on muscle aches, but they're specific just for the digestive system. So they're aminosalicylates. They don't really have the side effects that you see with steroids, such as prednisone, and they don't work. They're not as potent, so we use it more for individuals who have more mild disease.
What sort of problems can you have with that medication?
With prednisone?
No, with the other medication.
With aminosalicylates, you really don't see many problems at all. They're very easy to use. There are very few side effects. Someone may have an upset stomach or a rash, but that's really few and far between.
Is it pills that you take once a day, twice a day, all day long?
You know, depending on the one you use, it could be once a day up to 4 times a day.
So that impacts lifestyle if it's a medication that you have to take 4 times a day.
It is. The more often you have to take a drug, the less likely you are going to be compliant.
Right, right. Less likely you're going to take it.
That's right.
How about with prednisone? I'd like to get into a little more as far as other treatments, but prednisone seems to be really the prevalent one. What kind of problems can you see with prednisone?
Look, and prednisone is a very good short-term drug, but there are some side effects. Short-term, it can cause severe mood swings. It can cause insomnia, someone to get jittery. It can cause acne, weight gain, even high blood pressure. If you have diabetes, it can make your blood sugar go up. Long-term, it has even more serious side effects. The one that's most worrisome is osteoporosis. It can actually accelerate the onset of osteoporosis.
So what is osteoporosis?
Osteoporosis is when the bones get very soft. It's very soft
Never
and very brittle.
thing.
It's not a good thing.
And how about, how long, when you say short term, what's short term? A day, 2 days?
No,
month?
short term is, you know, a few weeks to 2 to 3 months. And if someone needs to be on prednisone longer than that, we usually go to other therapies. And the other therapies would be what we call immune modulating therapies or a new class of drugs called biologics.
So what are the immune ones that you were talking about? What are those like?
Well, as I mentioned earlier, Crohn's disease and ulcerative colitis are really autoimmune diseases. And what we try to do is modulate or suppress the immune system so it stops attacking our body. In an autoimmune disease, the immune system is actually attacking our cells, in this case, attacking our digestive system. And the immune modulators try to suppress that so it doesn't happen.
And then the biologics, what are those?
Biologics is somewhat of a scary name, but they're actually very, very good drugs that have been around now for 15 years. And these are drugs that are more targeted therapy that are approved for both Crohn's disease and ulcerative colitis. It's nothing we use as first line, but for individuals who keep needing to go on prednisone or doesn't respond to prednisone or is very ill, we may go ahead and employ these drugs, and they've proven to be very, very effective.
How about, so these drugs, my understanding is they have to be given, as we call an infusion. They must be given through the vein. They cannot be taken as a pill or as a liquid or something. Is that correct?
It's correct that these medications are taken either intravenously through the vein or you can get it by shot as well. But there is no pill form from it.
And what are the problems with the biologics?
Well, whenever you work on the immune system, one of the things we worry about is the development of an infection. Even something common like sinusitis or a urinary tract infection, if left untreated on these drugs, could get much worse. So infections what we worry about the most. These drugs, there may also be an increased risk of lymphoma or a malignancy. That's pretty rare, but it is something that has been reported and we do keep an eye out for.
So cancer, basically.
Cancer.
Any particular kind of cancer?
Really, lymphoma is the most common type. But
Which
again,
is?
Lymphoma is a malignancy or a cancer of the lymphatic system.
So of the lymph
Of the lymph
and
nodes.
things like that. Okay. How about surgery? Can you cut it out? Can you do something like that?
You actually can, and surgery is used very commonly for inflammatory bowel disease. And with ulcerative colitis, it's only disease of the colon. We really don't need our colon. It's nice to have around. So you could take someone, remove their colon, and they could live 100 years. So for someone who has ulcerative colitis that's not responding to therapy, surgery is a very good option. For Crohn's disease, we can also cut out that part of the small bowel, but Crohn's tends to come back. And so we tend to operate in Crohn's disease really only if we have no other choice.
When you said with the large intestine, one of the things I think of is a colostomy bag where a patient has to actually have their intestine connected to a bag which they have to wear outside of their body. Is that something that has to be done with this? Is that part of surgery?
Yes and no. That's one of the options. The other option is to use a small bowel, which again is perfectly healthy in ulcerative colitis, and use that to reconstruct the rectum, and so the person can go to the bathroom normally.
How about with the success of surgery?
Surgery is very, very successful. For patients who have had surgery for ulcerative colitis where they have the internal pouch made, over 90% will tell you that they'd be happy to have the operation again.
Ah, okay. And how about, obviously there's risks to surgery and that sort of thing, but I have to say that our time is almost up. So I would just like to have, if you would like to reiterate anything, if you would like to, something that we didn't touch on, now's your chance to let us know.
Well, the only thing I really want to mention is that Crohn's disease and ulcerative colitis are lifelong diseases and can be quite scary, but we really do have very good treatments now that weren't around even 5 or 10 years ago. So if anyone has Crohn's disease or ulcerative colitis or have symptoms of this, you really should consult your doctor, and particularly a gastroenterologist who specializes in Crohn's disease and ulcerative colitis, because there may be new treatments just out in the last year or two which could help you greatly and alleviate most of your suffering.
I think that's important to say because they're always making progress. And I can remember when the biologics came out, how wonderful they were for patients who really struggled with this. Well, thank you very much, Andy. I learned a lot tonight about this, and I think the explanation with the anatomy, going through the symptoms and the treatment and all that sort of thing was very interesting to us all. I appreciate you taking the time to be with us, and thank you again. For more information about Crohn's and colitis, visit the websites listed at the end of our show, or you can look for a copy of Dr. Warner's book either online or at your local bookstore. And to view past Physician Focus programs, visit our website at physicianfocus.org. I'm Dr. Linda Young. Thank you for watching.
I'm Dr. Andrew Warner. Crohn's disease and ulcerative colitis are two common forms of inflammatory bowel disease, chronic conditions of the gastrointestinal tract that affect hundreds of thousands of Americans. While the exact cause of these afflictions is unknown, they appear to be the result from disruptions in the body's immune system, which produces inflammation in parts of the digestive system. Symptoms of these conditions include abdominal pain, diarrhea, fever, intestinal bleeding or weight loss, and the effects on the body can range from mild to severe. If you experience any of these symptoms, see your primary care provider for referral to a gastroenterologist, a medical doctor specializing in disorders of the digestive system. A correct diagnosis is important as the two conditions, despite having similar symptoms, affect different areas of the body. For more information on these diseases, visit the Crohn's and Colitis Foundation at ccfa.org.
I'm Dr. Albert Grimaldi.
I'm Dr. Maggie Ham.
Hepatitis is a disease of the liver, a major cause of cirrhosis and liver cancer, a leading cause of death by infection, claiming some 15,000 lives each year.
Hepatitis is actually a group of 5 unrelated viruses, with one of the most common being hepatitis C. Most patients who contract hepatitis C develop a chronic or long-term infection.
More than 4 million Americans are living with chronic hepatitis, yet most do not know they are infected, putting them at risk for complications and increasing the likelihood of spread of the disease to others.
Some of the highest rates of hepatitis C appear in those born between 1945 to 1965, the so-called baby boom generation, and health officials are urging those people to get tested for the disease.
If you're in this group, call your primary care physician to arrange for testing. The good news is that hepatitis C can be successfully treated with medication.
For more information, visit the U.S. Centers for Disease Control website.